So you have the...
Thank you very much, dear Chairman, dear colleagues. My most sincere gratitude to the organizing committee for their kind invitation. So, let's move to the imaging of cholangiocarcinoma. As you know, these are malignant neoplasms arising from the epithelium of the biliary tree. They are bad tumors. They comprise 15% of primary liver malignancies, and most of them are adenocarcinoma. There are more rare histologies like squamous or clear cell, but adenocarcinoma is the most frequent. It occurs in elderly patients. You see that 63% of cases older than 65 years, except for patients with PSC or choledochal cyst, where they tend to appear 2 decades earlier. Unfortunately, they're associated with a very poor prognosis. Now, well, 80% occur sporadically, so there are no risk factors. However, for the rest 20%, there are known risk factors, and the suggested mechanism is chronic bile stasis and inflammation. So there are, you see here, common but also somehow different risk factors. For example, for extrahepatic, primarily you have choledochal cyst, you have Carroll disease, and primary sclerosing cholangitis, which is also, but to a lesser extent, for intrahepatic. For intrahepatic, keep in mind the cirrhosis and chronic hepatitis B, meaning chronic liver diseases. And unfortunately, even after resection of the choledochal cyst or resection of the stones, the danger remains. Okay, the first classification is based on location. So we have the hyaline cholangiocarcinoma, which is 50 to 60%. We have the distal one below the confluence of the cystic duct, which is another 20 to 30%. These both are the extrahepatic ones. And then you have the intrahepatic cholangiocarcinoma, which appears as a nodule within the liver. A second classification is based on morphology. Here we have 4 subtypes. We have the mass-forming, we have the periductal infiltrating, as you see here, the periductal infiltrating, and then the intraductal growth. This is the best prognosis, but also the rarest one. For the mass-forming type and the intraductal type, there is a tendency for longitudinal extension, so they grow along the bile duct, and they may extend beyond the macroscopic margin. For the periductal one, there is radial extension, so it goes deep to the submucosa and then to the rest of the layers, and then invades, as you see, perineural, vascular lesions, and perilymphatic extension. For intraductal growth, as we said, is the more benign. And of course, there are combined types. Usually there is a mass-forming and periductal. Another significant categorization is this based on their origin. So we have the small duct type. These are mainly the parenchymal ones, the ones that arise in the liver. And they occur from these small cells here in the canal of Herring. So these are frequent in parenchymal liver diseases like chronic viral hepatitis and cirrhosis, and there are no precursors. And then you have the large duct type, which arise from different cells. These are the cells, they're here, the ones in the peribiliary glands. So we are talking about big bile ducts, the large ducts, and these are frequent in PSC, choledochal cyst, and infection with flukes. Here we do have precursors, like the biliary intraepithelial neoplasm, which we will not see on imaging, or the intraductal papillary neoplasm, the bile duct, which sometimes they are detectable on imaging. These are characterized by abundant fibrous stroma, and they have a worse prognosis. So, small duct and large duct types. So, starting with the hyaline cholangiocarcinoma, the bismuth-Corlett classification is still in use. Bismuth 1 located to the common hepatic duct, bismuth 2 extending to the hepatic duct confluence, 3A extending to the right secondary duct confluence, and 3B extending to the left hepatic duct confluence. And then there is a bismuth 4, either extension to both secondary confluences or skip lesions. Of course, by itself, it is inadequate for staging because it does not give us information about the situation of the vessels, about liver atrophy or lymphadenopathy. Imaging modalities, of course, we use CT to detect the hyperdense stones, the arterial phase to increase conspicuity of tumor against the background and to evaluate involvement of arteries, and the portal phase to evaluate disease extent and detect metastases. With MRI, of course, we have the added value of diffusion-weighted imaging and the detailed anatomy of the biliary tree and, of course, its variations, which are also not assessed with the bismuth classification. Hepatospecific agents are not recommended, first of all because in cholestasis the drug is not taken up by the hepatocytes, and secondly because the avid enhancement of the liver obscures the delayed enhancement of the bile duct wall. PET is not recommended for primary diagnosis. It has a lot of false positives, especially after stenting with a biliary sepsis and infection. And of course, it has lower sensitivity for the ductal, for the infiltrating lesions compared to the mass-forming nodular ones. What we will see? We will see asymmetric wall thickening causing lumen stenosis and upstream dilatation, luminal irregularity. The wall is thickened, particularly more than 2 millimeters. Involvement tends to be lengthy, so we have more than 2 centimeters. And there is marked enhancement on the arterial and portal phase, and delayed enhancement if we have a scirrhous tissue in a mass-forming lesion. Associated lobar or segmental atrophy, either due to portal vein obliteration or due to biliary obstruction, which causes reduced liver volume with lower attenuation on the pre-contrast CT, increased enhancement of the arterial phase, and low T1 and high T2 signal. This is a case, a 50-year woman. You see here there is this thickening of the common hepatic duct. Again, the diffusion restriction on WI and ADC, and the enhancement on contrast-enhanced images. And then on the MRCP, you see here the disruption of the common hepatic duct. So it's a bismuth 1 subtype. This is an older lady. You see here on the contrast-enhanced that there are 2 adjacent tubular structures here and here. It's the confluence of the hepatic ducts. And you can see nicely that there's also involvement of the common hepatic duct. And then here on MRCP, you see the upstream dilatation. So it's a bismuth 2 subtype. Here, there is another older lady with jaundice and urine darkening. You see here, there is a dilatation of the left ducts and also of the left end to the common hepatic duct. Again, diffusion restriction, and the overview of the discontinuation of the biliary tree on MRCP. So involving the left secondary confluence, this is a bismuth 3b subtype. Now, the only curative option for these patients is surgical treatment. They have a survival rate of up to 42% after R0 resection, while for unresectable patients, 5-year survival is 0. However, even in high-volume centers, up to 50% of patients who were deemed operable are found finally inoperable in the theater. Of course, R0 resection improves 5-year survival, and an adequate margin should be pursued given the tendency to extend beyond the macroscopic lesion. Now, the traditional criteria of unresectability are the bilateral extension to secondary biliary radicals, or occlusion of both veins, or involvement of both lobes in either way. For example, biliary tree on the left lobe, or vascular involvement of the right lobe. However, nowadays, the current criteria are more a matter of technical feasibility, meaning it's unresectable if there is non-reconstructible vascular involvement and no possibility for radical biliary section. Of course, distal lymph nodes, meaning more distant than the hepatoduodenal ligament, are considered metastatic, for example, periaortic or SMA nodes. Distal metastasis may be to the liver, to the peritoneum, or to the lung, and of course, systemic comorbidities. Regarding vascular assessment, we do it exactly like the pancreas. We are only certain that the vessel is involved when there is encasement and marked stenosis or occlusion. Some examples, this is a young man. Here you see this bright T2 signal in the hepatic hilum with increased enhancement on the coronal post-contrast and the disruption of the biliary tree. So there's involvement of both biliary radicals. Again, here you see on the CT to better advantage that there is perivascular involvement, so extensive perivascular involvement, and this was considered unresectable. Another case, you see here, a 70-year-old man. He has this lesion here, which appears hypodense. There is some mass formation. Again, diffusion restriction, delayed enhancement initially, reduced enhancement initially, and here there is a disruption. So there is involvement of the, there is involvement of the right secondary duct confluence, and it's a bismuth 3A, therefore. It was considered resectable, so operation was performed. And indeed, the surgeon achieved an R0 margin. However, perineural spread and tumor emboli in veins were found. Now, the differential diagnosis. Please keep in mind that smooth tapering versus abrupt narrowing are seen in both benign and malignant strictures, and they are not reliable differentiating features. You see that asymmetrical narrowing is seen in up to 30% of benign strictures. Additionally, approximately 15% of presumed hilar cholangiocarcinomas are finally IgG4 cholangitis. Other differential diagnoses: primary sclerosing cholangitis, age-related cholangitis, recurrent pyogenic, ischemic, colorectal metastasis, and other infiltrative disease. This is a case of a 54-year-old woman with a typical epigastric pain for weeks. You see here there is a mass in the hilum with extensive perivascular involvement, extension. So this proved to be tuberculosis, luckily for the lady. Now let's move to the intrahepatic counterpart. Its incidence is increasing. Unfortunately, it does not cause jaundice, so it's difficult to diagnose in early stages. The majority are mass-forming, so you're going to look for a nodule. And it's a lobulated mass with irregular but rather well-defined margin. And as you all know, the viable tumor cells are located at the periphery, and the fibrotic stroma is seen centrally. Now, the imaging findings mirror the histology. So we have the central T2 hypointensity, which is the fibrostroma, and peripheral diffusion restriction, because the tumor cells are packed in the periphery. So the diffusion restriction, they are vascularized, so we have initially peripheral enhancement, but the contrast has no extracellular space. Then it washes towards the center, where there's a large pool due to the extracellular matrix, and then we have centripetal enhancement. It causes upstream bile duct dilatation. You may see vascular encasement without tumor thrombus, which is an important differential feature. Associated hepatic atrophy, satellite nodules, capsular attracture, and lymphadenopathy in up to 73%. On the hepatobiliary phase, you may see some paradoxical cloud-like central enhancement. It is not that there are tumors that uptake the drug. It is the drug that pulls into the large extracellular space. This is a typical example. In a 68-year-old lady, you see that there is peripheral T2 hyperintensity, peripheral diffusion restriction where the tumor cells are, peripheral enhancement initially, and then the contrast washes out from the periphery and pulls in the center. Typical appearance. A large tumor in a young woman. In younger patients, women predominate. You see here that there's capsular attractions due to the fibrosis. And also here, you can see that there is encasement of the portal vein, but without tumor thrombus. Therefore, this is not an HCC. No tumor inside the vein. Another case, a large tumor, irregular margins, but well-defined, with central T2 hypointensity, peripheral diffusion restriction where the tumor cells are, peripheral enhancement of the arterial phase, and then here Primovist was used. You can see that there is cloud-like central hyperenhancement because the contrast pulls in the intracellular and the extracellular matrix of the fibrotic stroma. Of course, we have atypical findings. A tricky one is the small tumors, which are more cellular with less fibrostroma, and you may see intense arterial enhancement and even with portal washout, especially in chronic liver disease or cirrhosis. So if you are lucky enough to see a targetoid appearance or a cloud-like hepatobiliary enhancement, you can differentiate. If not, you cannot. There is also the mucinous ICC with high T2 signal, rare subtype, and other differential diagnoses, metastases, especially from colorectal, which may also have central T2 hypointensity, the Skirus HCC, you cannot differentiate, and thrombosed hemangioma or rare lesions. This is a case from the literature, 71-year-old male. You see that there is increased arterial enhancement. I would say it's rather homogeneous, no rim-like enhancement. Definite washout, again, diffusion restriction, and no cloud-like central hyperintensity. So preoperative diagnosis was HCC. It proved to be an intrahepatic cholangiocarcinoma. Other differential diagnosis, this is a 72-year-old female, asymptomatic. You see here that there's capsular retraction, this hypodense lesion, but it's rather triangular, isn't it? And there's also peripheral enhancement, but no further progression of enhancement centrally. On MRI, you have the same features. You have the capsular retraction. You have no diffusion restrictions, however. There is peripheral enhancement that does not go centrally. And this proved to be a thrombosed hemangioma, proved by biopsy. Prognostic features: the small size, the absence of extension like satellite nodules, or the diffuse arterial enhancement versus peripheral, the low signal on hepatobiliary phase, and the large area, the homogeneous diffusion restriction. To summarize, the more the fibrosis, the worse the prognosis. And schematically, here on the right, you see the good humor, on the left, you see the good humor. There is homogeneous diffusion restriction, homogeneous enhancement, and no cloud-like enhancement with hepatobiliary. While on the right, there's a bad humor, the typical cholangiocarcinoma, peripheral diffusion restriction, peripheral enhancement, and central enhancement after Primovic. So the more the fibrosis, the less the prognosis, the worse the prognosis. Regarding follow-up, local relapse is the most common pattern, and the major prognostic features are the surgical emergent status and lymph node metastasis. There is no universal standard. You see suggestions, imaging every 3 to 6 months for 2 years, and then annually for up to 5 years. And imaging is done with CT of chest and CT MRI of the abdomen and PET for equivocal findings. This is a case of relapse, a young lady, you see with this very large mass with associated, as you see here, lymph nodes here and here. This is the surgeon's schematic before surgery. So right hepatectomy was performed, but you see that in less than a year, there are now at least 4 metastases on MRI. PET detects only 1 and possibly 2. So superiority of MRI regarding detection of metastases. For distal cholangiocarcinoma, it's located lower to the insertion of the cystic duct, 20 to 30%. It has this periductal infiltrating morphology. And again, we have indistinct margins, wall thickening, more than 2 millimeters, luminary regularity and asymmetry, long segment involvement, hyperenhancement, and diffusion restriction. As shown here, you can see the asymmetrical thickening of the duct with diffusion restriction, and on coronal CT, the increased enhancement. The differential for distal cholangiocarcinoma is mainly inflammation, so we have to exclude Ig4 cholangitis, particularly type 1, which involves only the ampulla of Vater, but you may also see other features, for example, autoimmune pancreatitis or infarcts in the kidneys. Primary sclerosing cholangitis with multiple stenosis and dilatation, only rarely involving only the extrahepatic ducts, so look for the intrahepatic as well. And HIV cholangitis, which behaves like infection because it is the low immune status gives rise to infections for CMV and other pathogens, possibly by causing ischemia. Here's an example with stenosis in the sphincter of Oddi. Now, a few words about cholangiocarcinoma in the setting of primary sclerosing cholangitis. There is a significantly increased risk. You see 160 to 400 times compared to the general population. Duration is not a risk factor because you see that half of cases present in the first year after PSC diagnosis. And there is overall a 20% lifetime risk. The risk factors are an older age representation and also if there is a coexistent IBD, inflammatory bowel disease, particularly ulcerative colitis. Look mainly in the hilum, 56% located in the perihilar region. And in these patients, annual surveillance is suggested with MRI and MRCP, with or without CA19-9, because approximately 10% of the population do not increase 19-9. There is a genetic defect. Liver transplantation is preferred over resection, but overall there are better results than de novo cholangiocarcinoma, perhaps due to the closest surveillance. Look for dominant strictures. A dominant stricture is the one that causes stenosis of the common hepatic duct or around the confluence, less than 1 millimeter, or if it is the common bile duct, less than 1.5 millimeters. There's a new definition which incorporates more clinical and biochemical data. However, as radiologists, we should look for this stenosis. And any mural thickness which is more than 2 millimeters should be considered abnormal, regardless of the site. Also, again, I repeat, irregular stenosis favor malignancy, but there is no definite distinction from benign lesions. You should check for any new or progressive lesions, focal mass with delayed enhancement, and associated vascular involvement. This is an example from the literature. You see here, there is the initial diagnosis of PSC, and this is just 1 year later where you see this mass-forming thickening of the duct. So, to summarize, there are bad tumors with bad prognosis, and surgery is the only curative option. The intrahepatic mass forming has a typical pattern with early peripheral and late central enhancement. However, be aware of atypical patterns. The hilar and distal cholangiocarcinoma should be differentiated from inflammatory diseases. So our role is very important because preoperative staging is absolutely necessary for the assessment of tumor resectability and patient selection. Therefore, our role is very, very important. And with this, I would like to thank you for your attention.